Hello, and thank you for joining us for today's training, Questions in the Field, How and When to Use a Child Advocacy Center. My name is Jamie Bolton, and I am the Director of Training and Development with the New York State Children's Alliance. Joining me today, we have experts in the field, including Dr. Rebecca Butterfield.
Hi, thank you so much for having me today. I really appreciate this opportunity to talk more about a subject that's very near and dear to my heart. I'm Rebecca Butterfield. I'm the Division Chief of General Pediatrics and Adolescent Medicine at Albany Medical Center. And I also am the Section Chief of Child Abuse Pediatrics here at Albany Med.
Thanks for joining us today. We also have Nancy Harris.
Hi, Nancy Harris. I'm with St. Peter's Health Partners and also am the medical manager for regional child advocacy centers in New York State. Currently, we are covering 21 areas.
Awesome. Thank you, Nancy. And
Thank
also Tammy Nicholson.
Good morning. Thank you for having me. I'm Tammy Nicholson, and I'm one of the supervisors for Saratoga County Child Protective Services.
Awesome. And also joining us is Jennifer Wormley.
Good morning, I'm Jennifer Wormley, the Director of the Child Advocacy Center in Saratoga Springs.
Thank you, everyone. Child advocacy centers serve as a resource to their communities when questions arise around the subject of child abuse and what to do, what not to do, who can help, and how does one find the appropriate services to help a family going through this process. Physician offices sometimes call a child advocacy center or CAC with questions, so we hope that this training will provide some answers to those questions most commonly posed to CACs. The goal of this training will include learning best practices when presented with a possible case of child sexual abuse, and understanding what a child advocacy center is and how it can help you when you are faced with a possible case of child sexual abuse. There are currently 46 child advocacy centers covering 61 counties in New York State. A CAC is a child-centered, neutral location where a coordinated child abuse investigation occurs. All CACs are based on the same national model designed to reduce the trauma experienced by child victims. One way this is done is by utilizing a coordinated joint investigation known as a multidisciplinary team, or MDT, which is typically composed of law enforcement, child protective services, victim advocacy, medical providers, and the county and assistant district attorney's office. If you are unfamiliar with the CAC that covers your county, you can find this information on the New York State Children's Alliance website, nyschildren'salliance.org. It is important to know that all CACs follow a specific set of standards that are set by both the National Children's Alliance and the New York State Office of Child and Family Services. CACs are held to these standards through an accreditation process and annual site reviews conducted by the Office of Child and Family Services. One of the major objectives of child advocacy centers is reducing the amount of trauma that is experienced by the victim and their families. So as previously mentioned, all of our practices are provided with what is called a trauma-informed approach. Nancy, how does looking at a child abuse case through the lens of trauma-informed approach impact the medical provider's response?
Well, it's important for the child to know that it's their exam and that we're going to take that time with them, give them that privacy that they need, and give them the time to be able to talk about what happened and to know that their body is okay. You know, that's the main thing that we want them to know, that they are okay.
Thank you. Tammy, in regards to gathering of information and details from the child and even the caregiver, the CAC recommends less is more. Can you explain what that means?
Sure. Many times as mandated reporters, when they're hearing this information from children and or caregivers, we talk about less is more in those situations because it's more important for the trained professionals such as the CPS workers and law enforcement who are specifically trained in the forensic interviewing of children to be able to talk to those children in settings like the CAC. The mandated reporters and even non-mandated reporters who hear this information, we always tell them not to continue questioning the child or the caregiver, trying to, clarify information or get additional information, because as we go back to wanting to reduce that trauma and re-victimization of the children, it's having them tell their story, the least amount of times possible. So once you hear that information and it gives that mandated reporter reasonable cause to suspect, they should follow the protocols in making the hotline report, determining whether the state central register will accept that report. And then, once it gets to the Child Protective Agency, coordinating with law enforcement to set those interviews up, with the goal in mind of just having that child tell that story, hopefully one time. So it reduces the re-victimization and the telling of that story over and over again.
So if I have a concern or a child comes to me, you're saying that I shouldn't be asking questions to get more details.
You can ask questions to kind of clarify what you're hearing, but interviewing a child or trying to follow up after maybe the child's gone, no, we don't recommend that. If you have reasonable cause to suspect based on what that child has told you, you make the call to the state central register, and then we can take over from there to clarify the information. Reasonable cause to suspect is just something that you believe, if it was true, could constitute abuse and neglect. It's not the mandated reporter's job to kind of investigate it. And that's our job. And that's why you should just make the hotline report at that time.
Awesome. Thank you. Nancy, do all children who may have been sexually abused need a physical exam?
Like I mentioned earlier, it's important for every child to know that their bodies are okay, even if it's just touching. So many times we hear that, oh, it was just touching, and there may be more. And the child may also have questions about their body, even if it was just touching. And we know in medicine how important the ACEs study is, and how important it is for the children to know in that very beginning that they are okay.
In certain instances, a referral to the emergency room should not be the first step. Why is that the case?
Many times children don't disclose right away. So it may have been an incident that occurred months ago and they do not need that emergent care. So it's important for them to reach out, call the CAC, and that way they can assist in that coordination of care. And it's just less stressful for that child to be in the Child Advocacy Center than into an emergency department.
Okay. Do all child advocacy centers provide on-site child sex abuse examinations?
Not all of them do. Some of them may refer to an emergency department, but the calling of the Child Advocacy Center nearby you will definitely help with that coordination of care, because they may be able to find the provider who will be able to cover that child at that time. And then the family is not waiting in an emergency department for hours for care.
So who's qualified to provide these exams?
So most of the time in the emergency department, it would be, a medical provider, the physician in the emergency department, or a pediatric SANE trained provider. But not every of the facilities in the emergency department have that. So at the Child Advocacy Center, our providers are SANE P, which is a national certification. And we also have medical directors who oversee and provide us with trainings as needed. And we want to make sure that we're providing the best care possible for the children.
Awesome. Are the child sexual examinations that are done at the CAC the same as what would be done at the emergency room?
Yes, if the Child Advocacy Center is based with labs, being able to collect all the laboratory specimens, and also we're able to give scripts for the medications. That is one thing that in the emergency department, it is nice because they are able to get the labs and get medications if needed. But most of the child advocacy centers, you would be able to reach out to and find out if that's the best location for them. But every exam is performed the same way. Starts off with that medical history, the assault history, a head to toe assessment, and then we are all concerned with safety at discharge.
Awesome. Thank you so much, Nancy.
Mhm.
Dr. Butterfield, can you please explain the different classifications of triage, such as emergent, urgent, and non-urgent?
Sure. Nancy kind of went into this a little bit, but the vast majority of children actually can be evaluated outside of an emergency room setting. So children should be triaged for an emergent ER evaluation if they are in imminent danger or if they have any medical complications of suspected abuse, like abdominal trauma, head trauma, loss of consciousness, etc. Other things that would indicate an emergent ER evaluation would be prepubescent vaginal bleeding, any genital pain, any possibility of pregnancy, a need for medications for STD prophylaxis, and a need for forensic evidence collection. And then, of course, if there's a psychiatric emergency, if the child is at risk for self-harm. Urgent evaluations are those evaluations that should be recommended within 24 hours or so. Those children are safe and not in imminent danger. There's no imminent medical emergence concerns, but they have findings that may resolve quickly, like bruises or symptoms that need addressing, like vaginal discharge. Evaluations that can be scheduled, i.e. those evaluations that are less urgent, are children who report abuse not within the last week. If the nature of the abuse is unlikely to result in any physical findings, if the child is currently in a safe environment, if the concern for abuse is really stemming from a behavioral problem rather than from a physical problem.
Fantastic. Thank you so much. Nancy, when appropriate, why would a CAC referral be more favorable than going to an emergency room, and how is that done?
Well, the nicest part about it is being able to have that private, comfortable area. And there's only one family there, where, in an emergency department, you're, with everyone, and it's not always as private. There's also that improved communication amongst the team members. We're really able to discuss with each other and kind of make it work the best for the family so that we're all there at the same time. The triage is just a lot shorter. It's really one-on-one with the child and the family. The support staff is there. We always make sure that we have counseling. We want to make sure that there's counseling for the family members as well as the child. Any emergency needs that we need to have taken care of, we can set up at that time. It's also a free service. So just like the hospital, we do offer the Office of Victim Services so that there are no bills sent to the family.
Fantastic. Tammy, if it's determined at the physician's office that the medical aspects are not critical, then the most important consideration should be to make the report and determine if there is any imminent risk to the child. For example, if the alleged abuser is the alleged abuser in the office with the child, what would your recommendation be if that were the case?
That's a good question, and that comes up quite frequently when we talk about cases like this. I think for the mandated reporter, it's important for them to remember that less is more. So again, there may be the need to want to continue to question that child to find out if there is an immediate safety need. But if they have the reasonable cause to suspect and they make the hotline report, you may not know at that time if that child is in an imminent danger or there's an immediate safety concern just because the alleged abuser is with that child. So we would recommend making that hotline report so the Child Protective and law enforcement can coordinate, and they can make the plan to get the child to the CAC for that interview and medical and what needs to happen. As always, we tell people if there is an immediate safety concern to call 911 in those instances. And if they are, questioning that, to start with the state central register to make that hotline report. Many times before the family even leaves, they do that, and then they can process through with the state central register if there's an immediate need, and they may be advised to call 911, but most of the times they accept the report and then CPS gets involved so we can coordinate safely for that child to be seen at the Child Advocacy Center.
Awesome. Thank you, Tammy. Dr. Butterfield, what are the common misconceptions about child sexual abuse examinations?
There are a few common misconceptions. First, a lot of parents are concerned that the exam itself will be invasive or traumatizing to the child. We always point out to families that internal exams or exams with speculums are not indicated in prepubertal children without anesthesia, and that is very uncommon. So the majority of these exams are really not very different from a typical medical exam that the child's used to in their pediatric medical home. The other common misconception is that these exams are only done for evidentiary purposes. So if forensic evidence is going to be collected, but frequently these exams are done long after the evidence collection period has passed. And as Nancy pointed out in earlier questions, is really important for the overall health of the child to ensure that the child is overall healthy and to emphasize to the child that they are healthy. And then finally, another common misconception is many parents think that we can tell by doing an exam that the child has been hurt or abused. And the majority of the time that is not the case. So the majority of child sexual abuse victims have normal genital exams. So the absence of findings does not mean that no abuse happened.
Awesome. Thank you for sharing. Tammy, we mentioned calling the state central registry or the hotline for cases where the suspected abuser is an adult. What if the suspected abuser is another child or even a sibling and not a person legally responsible for the child? We know there is not a mandate to call the SCR in these circumstances, but why would it be important to make these calls anyway?
I think when we talk about a mandate for these types of situations, we'd like to remind mandated reporters that it doesn't, while it's not child on child sexualized behaviors, there's not a specific mandate for that. What we're concerned with is that a parent or caretaker was not protecting in these situations. They may have had information that they knew that these behaviors exist and they did not protect. Or that could have led to the child being victimized or children being victimized. And so best practice would state that if you have a situation like this and you're not sure if the parent or caretaker knew, to make the hotline report and let the state central registry make the determination about whether it will be registered as a hotline report. And the importance for that is getting that child, the child who was victimized, into the CAC so a forensic interview can be completed. And it's also for the child who perpetrated that they can be interviewed as a potential victim. More times than not, these behaviors stem from some place, and through those interviews and investigations, we can figure that out. And that's important to happen through the Child Advocacy Center, where it's a safe place for those children to be interviewed.
That makes a lot of sense. Thank you. Dr. Butterfield, we don't want our physicians to worry about losing a child or children as patients. Isn't it challenging for a physician's office to continue to work with a family after they have hotlined possible abuse?
It is challenging, but I think it's really important. So the alternative is to not identify abuse and leave a child at risk for future abuse, including risk of death or further harm. So I think my solution is to be very honest with a family. I almost always tell families that as a mandated reporter, I have to report this concern for abuse to them at the time that I'm doing it. And I emphasize that I want to continue to work with them going forward for the benefit of their child. And believe it or not, it actually sometimes is very successful. I I think if the family sees you, the doctor, as the advocate for their child, I think it isn't always, a dramatic, chaotic scene. It can be very helpful, I think, overall.
That sounds really great. Thank you. Dr. Butterfield, Nancy, and Tammy, I think we were able to answer some great questions that have been posed by CACs to CACs by physicians. And we covered some important topics that are really important for these physician offices to be aware of. For you, the person who's watching, we know that these cases can be complex, and we hope that you will feel comfortable reaching out to your local child advocacy center for assistance when appropriate. And as always, we are here to help. So thank you so much for joining us today.
Thank you.
Thank
Thank
you.
you.